Thank you, Mona. I must say I'm delighted to be here, and I'll tell you why in a moment. But this is a fantastic celebration, wonderfully led by two of Canada's most outstanding leaders, John Dirks and Pierre Mulien. And you will notice at this particular that there is another address there, and that I'm commuting between Vancouver and Tel Aviv at the moment. It's a long commute. And in fact, last week, I wasn't sure if I was going to get here, because I was in, the rockets were falling on Tel Aviv, and I was just very close to calling John and Pierre to say, it's time to think about someone else, and I had some suggestions. But fortunately, the ceasefire is held, and I'm out of there, and so I'm able to tell you a little bit about some of our own work in pharmacogenomics, which is really conducted as part of a big Canada-wide network, which I'll tell you about. It's co-led with Bruce Carlton, a colleague of mine at UBC. And essentially, this is the problem. The problem is that essentially when we start doing drug trials, essentially these are generally given, often there's not a lot of dose finding that goes on. We use these drugs in usual doses in populations, and the main issue and the major goal is to really show that they're effective and also safe. But of course, as we go to phase 4 and look at much more detailed studies, what happens is we recognize that 50% of patients, even if you've shown efficacy, do not have efficacy to that particular medication. And between 15 and 20% of patients end up having very severe adverse drug reactions. So this is the background. This is the big medical problem that we've tried to address now using genomics technologies within the Canadian population. The frequency of these are well seen when you look at just the emergency rooms here, about 12% of emergency rooms here in Vancouver, in the Vancouver General Hospital region, all due to side effects of drugs. And again, this is throughout the country. So this is a major issue. And if you look throughout the rest of the world, certainly the United States, we're looking at this as the 4th leading cause of death, 7% of all admissions, and the healthcare costs are really dramatic in terms of the impact on the healthcare system. So the issue that we've been focused on initially, although now we're extending into adults, is that within children, much neglected, ADRs also are playing a very, very significant role. Many hospitalized children have an ADR. If you look at the oncology wards of all the children's hospitals throughout Canada, about a quarter of the admissions are due not to the cancer itself, but due to the side effects of the cancer. And generally, these side effects are, in fact, very severe and have long-term disability. So the real problem has been that many of these, even though there's compulsory registration for serious adverse events in Canada and in many other countries, in fact, when you look at those that have come to the hospital and then seen which of those are reported, in Canada, the numbers are really quite shocking, around 4%, but these are very similar. Here's Germany, about 2.5%. So the real problem is that most ADRs are not reported. And so as we started contemplating how to address this, we knew that we needed to have a different strategy. And Bruce and I set up the Canadian Pharmacogenomic Network for Drug Safety about 6-7 years ago now. This has involved active surveillance. In other words, we're actually actively having people situated in the emergency rooms across the country. We collaborate also with all the pediatric centers in the country, primarily because many of the side effects in children were occurring in children suffering from oncology and oncological problems. So we have a defined, dedicated ADR surveillance approach. As part of this, there's a very detailed clinical history that's taken, blood's taken, there's an appropriate assessment, standardized assessment of the ADR, the history, the ancestry is taken, and we have about 95% or greater than that success at recruitment. So as a result of this, we've been able to now put together the largest collection of ADR cases and controls in the world. Currently more than 50,000, where all these records are fully documented online, tissue samples, urine where appropriate collected, and this has then represented the resource that we've actually been interrogating in terms of trying to understand the genetic basis for some of these serious adverse events. Our initial approach was not to really go in with a particular side effect that we wished to assess, but rather to see what was prevalent in the Canadian children, in the population of Canadian children, that warranted further investigation. And what we, of course, recognized very early that the vast majority and a big proportion of the children suffering with serious adverse events were children treated with cancer, and many of these children were surviving. About 75% of cancer patients are surviving now, and when there is a serious adverse event, this is again life-threatening, and again, large proportion of the admissions to the children's hospitals in oncology are due to some side effects of the drugs. So we really then set out to determine, we had a very good assessment of the environment of these children, both body mass, various other parameters, age of development, various other parameters of development, and essentially we've been looking for those children that also had the most severe adverse event, what we've used in many other genetic approaches, which is the black swan, that unusual event that really teaches one more about the general physiology. And in this particular instance, you could call it a white penguin too, we were interested in those that were outliers. These were children that had very severe effects that we caught early, extreme impact, and allowed us to then develop paradigms for predictability going forward for other children with this particular genotype. And the ones I'm going to talk about today are those that are very well developed, in particular anthracycline and cisplatin, which represents children treated with cancer, and then also warfarin, a very commonly used anticoagulant in adults, but actually very commonly used in children too, for which very little data has been available with regard to prediction of side effects. With regard to anthracyclines, this is highly effective. It's really been one of the reasons that children's cancer rates have substantially reduced. It's given to most children with cancer, both leukemias and solid tumors, also in adults. And there are about 1 million patients a year that are receiving this in North America and Europe. Here's, for example, one of these unfortunate situations, rare events, where a healthy child here presented with neuroblastoma, began doxorubicin, and essentially prior to the last cycle of treatment, had a routine scan, became very unwell, had developed serious cardiac dysfunction, intubated, was placed on ECMO, received a heart transplant. The heart transplant was rejected. A second heart transplant was given, and this child is now in remission. And this is a child that really was epitomizing some of the big, more severe than many, but in fact, anthracyclines causing serious cardiac toxicity. And in fact, the younger the child, the higher frequency of this cardiac toxicity, and particularly in children less than 4 years. And if you do go into cardiac failure within 1 year of getting therapy, generally about 70% of these children will die. So you may survive the cancer, but you will die as a result of the side effect of the therapy. So we initially started off using Canada gene approaches, essentially looking at the ways that these various drugs were metabolized and set up through panels that we constructed, initially in collaboration with colleagues at Genome Quebec. And very importantly was the phenotypic characterization of these patients. In particular, we focused on the most severe patients, grade 3, grade 4. These were patients who had difficulty walking, an ejection fraction that was low, and here, grade 4. These are patients that are generally going to require heart transplant, and these are patients actually in congestive heart failure. And that again allowed us to separate the signal from the noise in terms of looking at the severe side effects. And essentially our approach generally was to start off using the Vancouver cohort as the discovery cohort, with replication both in other regions of Canada as well as in other regions of the world, in an effort to see how generalizable these were. So with regard to this particular side effect, what we see here is that we were able to report just recently this year, both in discovery and replication, very similar, a very significant protection with a certain allele in this particular transporter, SLC28A3, and I'll tell you a little bit more about it. So this was able to protect who would be protected as a result of this. We were able to replicate this again in another cohort from the Netherlands, and when you looked at this, the total numbers here are significant, but again, all of these were able to show the same in populations of Caucasian descent. One's able to really predict who's likely to be protected and who's likely to go into heart failure. Furthermore, when we looked at a select group from Canada, but people of non-Caucasian ancestry, again, we were able to get some evidence that this was likely to be generalizable not only to European populations, but to those from other parts of the world, even with very small numbers. And this is because these patients are severe. One's able to have a high power for detecting these particular associations. Now, this particular transporter, it's a sodium-coupled nucleoside transporter. It transports pyrimidines and purines. It's already been shown to have a role in anthracycline transport. And in fact, the allele that we're actually looking at here, which was part of this array, is associated with reduced RNA expression. And the hypothesis that we're now testing in vitro is that this decreased expression would result in decreased uptake and decreased generation of these toxic metabolites associated with this. So as a result of this, we've been able to continue and actually develop various variants that would be actually Kaplan-Meier curves that give some indication over time for the predictability of this particular allele. And what you can see importantly, that firstly there's a group of about 46% of these children who are getting therapy who are going to have less than 4% likelihood of going to cardiac failure. This immediately allows one to have less significant, less frequent follow-up of those patients. And then there's another group of patients who are at high risk, 17%, who are going to go into heart failure within about 6 months of therapy, and this increases dramatically up to about 90% risk. So this allows one to stratify this particular population. We've now gone on to look at a whole set of other markers, including a much broader scan, and now a whole genome scan, and this particular curve is getting much tighter. But in fact, the same principles hold, with this being the major variant conferring susceptibility to this particular very serious side effect. You may say, who cares? Why? What does it matter? Well, in low risk, certainly these patients, you just looking at echocardiogram follow-up. Intermediate risk, it would be more intense. And high risk, one really has to think about an altered medication. There are cardioprotectants you can treat with, and you can also start treating very early with various drugs to protect these hearts against further damage. So there are approaches you can take prospectively that really can influence the way these children are managed. And we're now just reviewing the data and already new data with regard to genome-wide association, and have expanded this to adult patients, again, with results that look very similar. This has not been done in adults. The results in adults look very similar for this particular marker and variation in this marker as predictive of cardiotoxicity in adults, although the frequency of toxicity is much lower. Cisplatin, another drug, very highly effective drug, particularly for solid tumors, particularly in children, CNS, another. And in North America and Europe, about 1 million patients a year. Again, very, very highly used. Again, we've replicated variants of this, so this has been published, associated with cisplatin-induced deafness. We've done 3 replication studies here, initially in BC, the BC cohort, and then a Canadian replication, another Canadian replication, and this is a new cohort that is constantly coming in terms collected over time. We've also repeated this in the Amsterdam cohort, and the combined cohort has, again, very significant odds ratios. And if you look at this, the ability to predict who will go deaf is really greater than 90%. So here, if you have some of these variants in TPMT and a few other genes, the likelihood that you will go deaf is greater than 90%, or that you, and if you have those variants, the likelihood of being normal is 7%. Odds ratio is significant, and this is very relevant. As a result of just these studies in humans are now also replicated in unpublished work in adults who are being treated with cisplatin for testicular carcinoma. The FDA has now recommended, as of this year, changes to the FDA-approved label to include the safety update on cisplatin-induced hearing loss in children. So this is already recommended by the FDA based on this particular information. And again, there are new options associated with this, carboplatin protective strategies. There are strategies that can protect it. It's more expensive, but still very useful. Increased monitoring, and where appropriate, you can actually reduce the dose. That is very dose response and dose related, and where the reduced dose has been shown to be efficacious, one can look at a reduced dosage. We are now involved as funded through Genome BC, and the initial work that we've spoken about is funded through Genome Canada, but now we're focusing on implementing this in British Columbia. We have and this is both for anthracycline and cisplatin through all the cancer sites across the province. We're doing genotyping, and we're working to both assess these patients going forward, we're implementing that, we're providing all the information to patients and their families, and they are choosing the options they feel are most appropriate, monitoring this as we implement this and show that this can be done effectively through the cancer centers throughout British Columbia. We also are developing practice guidelines that are going to be implemented and published very soon with regard to this particular approach. That's really part of working with clinicians, patients, and families, bringing the patients' families into this discussion about what's appropriate in terms of management and development of the appropriate guidelines as we generate new evidence with new markers that are tightening up this particular prediction in an effort to really provide the most appropriate care to patients. This has been led by clinician scientists, treatment teams, and a clear, certified and appropriately certified diagnostic lab that we're able to now to take this information and translate this initially for the benefit of British Columbia, then Canada, and then hopefully globally. And this particular program is also looking at utility, cost effectiveness, looking at an appropriate ADR prediction program in British Columbia, and also playing a role to educate and train the family physicians, the oncologists, various people throughout rural regions of British Columbia in an effort to really be able to implement this. Let me talk about warfarin. Warfarin is a drug that's the most commonly used prescribed oral anticoagulant, 2 million people each day in the United States. It's also the most commonly used anticoagulant in children. And as you know, warfarin works by inhibiting VCORC1, which is crucial in generating vitamin K. And so if you just look here, warfarin inhibits this, decreases vitamin K, and decreases the activation of various clotting factors, resulting in decreased clotting. There are various alleles associated with VCORC1 that have been shown in adults to really have impact on the dosage. And it's often very difficult to find the appropriate dosage that is sufficient to give the appropriate monitoring that will allow the appropriate level of anticoagulation without too much bleeding or too little anticoagulation and thromboembolism. And so, of course, if the dose is too low, the likelihood of getting clots, and the dose is too high, and very often these side effects are common, up to 35% of patients. And certainly for adults, this has been long recognized that, in fact, pharmacogenomic testing has been recommended by the FDA. So these variants, which are VCORC1, which generates vitamin K, and is inhibited by warfarin, and another one, CYP2C9, which breaks down warfarin. These are two key genes that have been shown in adults to be important in terms of defining dosage, appropriate dosage for warfarin. And in the USA, it's estimated that if this was properly implemented, which it hasn't yet been, but still, this has the potential to save very significant dollars, prevent numerous strokes, and prevent large numbers of bleeding incidents. And the question that has been asked is, what about children? Children are different. Dosages are different. These doses are influenced by height, weight, stage of development, which influences the genes involved in pharmacogenomics, and in particular in these genes. They're different at different ages. And what do we know about warfarin testing in children? So what we do know, there have been some very small studies be done before on small numbers, up to a total of 150 patients. And for VCOR-C1, there has been an association, but it's been mild. And the role of CYP2C9 has been unclear. And so the question of whether these genes are really predictive of ADRs in children has been unknown. And we've been able, using this network now, to try and address this in these children. So we've recruited now 128 patients. Essentially, we've been able to look at the appropriate dose of warfarin, which essentially would be no dose change because the INR is in the appropriate range. We look at the time to INR, and that's the time to get to that dosage, and also look at various classifications. And this is the group of patients. What you can see is the patients themselves. Some of them have had pulmonary embolism. This is a cardiac early. These are young children with congenital heart disease, heart valves, cardiomyopathies, and other essentially instances where these children are already very sick. And the question has been, how do we get the appropriate dosage? And it's inordinately difficult in children to get the appropriate dosage of warfarin in these situations. So what we were able to show, and this is all unpublished data, essentially that, in fact, if we took together the clinical and genetic factors, these are accounting for about 76% of the dose variability in children. This is higher than in adults. In adults, between 50 and 60. So, in fact, one's able to provide better variability. And as you can see, you're looking at various genotypes here. AA, for example, these are associated with a lower dose of warfarin that's appropriate. And as you go to GG, higher. So these are children who have the AA genotype that really, if treated with the regular dose of warfarin, would have a much higher likelihood of bleeding because they're actually sensitive to warfarin, whereas these children would have more chance of having thromboembolism at the appropriate doses because these would be children that need higher doses of warfarin. So already now there are algorithms being developed that we've instituted and are looking in a pilot way in an effort to see whether these are appropriate for clinical utilization for children initially in British Columbia and then elsewhere.